You're welcome to my channel. Today I'll be addressing the use of certain antihypertensive agents in some patients with hypertension and some certain comorbidities. Don't use antihypertensive wrongly. Wrong medications will not help you, and it will not help your loved ones as well. That is my advice to patients who will need antihypertensive agents. Note this: you are different from your neighbor. You are not the same as your friend, sister, or brother, because some will come and will request for certain medications saying, that's working for my friend. He was diagnosed with hypertension so years ago, or working for my neighbor. Your doctor will make that determination based on certain comorbidity or morbidities found or not found in you. We may be doing more harm than good if we think we must be using the medications that other people are using. For example, someone is hypertensive and at the same time asthmatic. In this patient, we will not use non-selective beta blockers like Propranolol. So if your neighbor is using Propranolol and he or she is not asthmatic, but you are asthmatic, you can't force your doctor to give you Propranolol, because he will know better, she will know better, that won't be helpful to you. As a matter of fact, that can kill you. The reason is that we have beta-1 in the heart. So your doctor may choose beta-1 selective like Atenolol for you. The beta-2 is found along the bronchus. You need that to help in expanding your lungs because of your asthma. And that is why Salbutamol is prescribed so as to be able to dilate the bronchus with the help of the beta-2. But if you're on steroid for a long time, the explanation will be given that the steroid you are taking will shoot the BP up. The salbutamol may shoot the BP, but not so much. We can always choose from other antihypertensive agents. The story is the same with COPD, just as found in asthma. You can rewind and play that of asthma again. No non-selective beta blockers in COPD. You may choose beta-1 selective that will work on the heart. We can choose from other antihypertensive agents. We have a lot of them. You can check my channel for that. I've published all the list of antihypertensive agents available as of this generation. If on steroid for a long time, note, steroid may help in shooting up your BP. Salbutamol that you are taking may shoot the BP, but not so much. If you have hypertension secondary to pheochromocytoma, phentolamine or phenazobenzamine will be helpful, but you need surgery. In pulmonary edema, want to flush that out, can use LASIs, that is furosemide, torsemide, or bumetanide. But in patients who are allergic to sulfur, like in Septra, they will also be allergic to LASIs. Therefore, you use etacrinic acid. All of them here on this page, they are all isolin diuretics or loop diuretics that could help in draining the fluid from the lungs. So in pulmonary edema with hypertension, isolin diuretics. But if there's allergy to sulfur, go for etacrinic acid. In aortic dissection, you see the beta blocker I've selected, and of course surgery will be curative. In cocaine, no beta blockers. Why that? Full explanation already published on my channel here. Just check No beta blockers in cocaine. I've already published that. If you can't use beta blockers, what can you use? You can use non-dihydropyridine calcium channel blockers. Like what? That is verapamil or diazepam. You can check my channel for that. In coarctation or filter, you need surgery. But no doctor will be watching you until the surgery is done. We need to bring that BP under control, right? So antihypertensive agents will be selected based on other conditions around you. If there's benign prostatic hypertrophy or benign prostatic hyperplasia, alpha blockers will be the first line. In hypothyroidism, okay, here we go. Propranolol that I did not accept in asthmatic patient will actually be useful here in hypothyroidism. But no detailed history will be taken, making sure you are not having asthma with the hypothyroidism. In osteoporosis, we'll make use of thiazides. Not because they are super excellent, but because thiazide has one side effect that will be helpful here, and that is hypercalcemia. In gout, we will run away from furosemide, we will run away from thiazides. In hyponatremia, of course, we will not expect high blood pressure in hyponatremia, right? In case that is the situation, meaning there's high blood pressure and there's hyponatremia, we will not give thiazides here. We can use loop or otherwise known as high-cylinder diuretics, like furosemide, but we'll be very cautious. In sick sinus syndrome, we will not use any medication that will work on nodes. So beta blockers, non-dihydropyridine calcium channel blocker like verapamil or diazepam will not be used. In heart blocks, just as in sick sinus syndrome, we will not use beta blockers, we will not use non-dihydropyridine calcium channel blockers. The other medication that can work on the node is digitalis, but I'm not dealing with that today. I'm dealing with hypertension and certain other comorbidities. In hypertension with ascites from liver cirrhosis, liver failure, go for spironolactone first. If you are not winning, have furosemide. You can add the third one, metolazone. But never, never bring metidopa near anyone with liver failure. Why that? It may lead to severe or fatal liver injury. In angioedema, no AC inhibitors. You might want to job at choosing angiotensin receptor blockers, but do that cautiously and better still, contact your pharmacist. In pregnancy, we will not use AC inhibitor, we will not use angiotensin receptor blockers, we will not use eliskir. At this juncture, if you are confused, just contact the OBGYN around you. I mean OBGYN specialist around you. But if you are by yourself, you can start with metidopa if there's no liver pathology. You may start with Atenolol, but keep an eye on the value of the blood pressure. Adrenaline is helpful, but should be used cautiously, particularly when you are giving it intravenously. Okay, be very, very cautious with adrenaline and Atenolol. Why that? The BP could be crashed down. Nifedipine is second-line agent here. Like I've said, discuss with the OBGYN specialist and of course your pharmacist. In blacks, The first to be considered is diuretics because they battle with fluid overload more than whites. You can use dihydropyridine calcium channel blocker like nifedipine, amlodipine, and so on. You may, but you use these less, that is beta blockers and AC inhibitors. But that is when you are comparing these to whites. Okay, we will soon get to whites. Here, the AC inhibitor will not be what you put down again because nowadays anyone with diabetes mellitus, whether with hypertension or not, he or she will be placed on AC inhibitor, okay, for cardiorenal protective purposes. Okay, so white selection. In white, you will start with AC inhibitor or beta blockers. You are not going to throw diuretics away, but when you compare the treatment to blacks, where and when you would use diuretics as first agent, you are going to use diuretics as the second line agent here compared to blacks. In heart failure, no calcium channel blocker, no spironolactone. Why that? Spironolactone is potassium sparing. Amiloride is the same, and triamcinolone will do the same. All potassium sparing diuretics will not be used in heart failure. You can use ACE inhibitors, you can use beta blockers. In post-myocardial infarction, spironolactone is welcome. You can see when you go through this list, some funny things are happening. I will tell you, don't use propranolol here. I will tell you propranolol is welcome here. I've just said, don't use spironolactone in heart failure. Now, in myocardial infarction, you can use spironolactone, but watch your potassium level. You can use beta blocker like Atenolol, ACE inhibitors, and ARB if there's reaction to ACE inhibitors could be used. Nigeria, nitroglycerin could be used, but watch the BP, please, and find out if the patient had already taken, Levitra, Viagra, Cialis. You understand what I'm talking about? Phosphodiesterase 5 inhibitors. And of course, you can use calcium channel blocker and beta blockers in angina with hypertension. In hypertension with atrial fibrillation or atrial flutter, non-dihydropyridine calcium channel blocker will be the best with beta blockers. Digitalis will be helpful, but I'm not dealing with that today. I'm dealing with hypertension and certain comorbidities. In diabetes mellitus, like I've said just within a few minutes ago, that ACE inhibitors are prescribed right now in diabetes patients. The only thing we need to do is make sure that the dose of the ACE inhibitors will not affect the blood pressure in a bad way, adversely. So, ACE inhibitor like Ramipre is being prescribed right now to all patients with diabetes mellitus. But when there's a reaction, we give angiotensin receptor blockers. But we will not give thiazide in diabetes patients. And why that? Thiazide has hyperglycemia as part of the side effects. In migraine, calcium channel blocker is welcome. Beta blockers will be welcome. Lastly on my list here is renal phenomena. And here you can give calcium channel blocker like nifedipine. With that, I come to the end of this very list. Though this is not the end of it. For example, if a man is impotent and at the same time hypertensive, don't give beta blockers. You will worsen the situation. Choose calcium channel blockers for him. Okay. Thanks for listening to all my presentations. Please remember to share this very one. And remember where we started from. If you're a patient, if you are not a healthcare worker, that stop dictating to your doctor the exact medication you want because you're the one taking it. Okay? because your doctor will judge what you need based on other situations around you. Remember to subscribe to my channel so that you can get this presentation and many more immediately they're published. I appreciate it.